Hi there, my name is Dr. Amit Keswani. I'm an interventional cardiologist here at Williamson Medical Center. You're listening to Health Talks from the Inside Out.
Dr. Amit Keswani, thank you for joining me today on the podcast. You are one of our interventional cardiologists here practicing at Williamson Medical Center, but you hold a few different titles, so I'm going to let you introduce yourself, if you will.
I do. First of all, thank you for having me. I appreciate that. Yeah, I do wear a few different hats here. I am our regional medical director for Ascension Saint Thomas Heart through our Southern Corridor, and then I also am the committee chair for our primary heart attack committee here at Williamson Medical Center, where we have our chest pain center accreditation.
Yeah, that's great. And we're going to get into that in just a minute.
Yeah.
I do like to begin these conversations by asking, what drew you to medicine? What initially set you on this career path to where you are today?
Yeah, that's a really good question. I love people, but I had zero interest in going to medical school.
Okay.
Yeah, so my father, he was an engineer. My grandfather on my dad's side was an engineer. My uncle was an engineer. So I really didn't know what to do.
Right.
But I said, hey, maybe I should be an engineer.
Yeah.
So I went to Georgia Tech in Atlanta, and then when I was a junior in college, my dad actually had a heart attack. And so that was kind of a challenging time. I was getting close to finishing my degree, and I was still trying to seek purpose.
Yeah.
And sometimes, you're spoken to and you have to listen.
Yeah.
And so that was very trying. And he did not get the care that I thought was appropriate. So for me, it was sort of, in some ways, really prophetic or helpful to guide my career choice because I was a little lost.
Yeah.
And so I told him, I said, hey, I think I'm going to go to medical school. And the first thing he said was, well, you're already a junior, so maybe you should finish your degree first.
Yeah.
And so I promised him I would do that. I worked for a little bit, and I really didn't enjoy my career choice.
Yeah.
So I went back to school, did a post-baccalaureate degree in biology. I worked full-time doing research at Baylor Medical Center in Houston, where we did kind of basic science bench research, and I really fell in love with cardiology then.
Okay.
So we did procedures in an animal lab. So I learned how to do heart catheterization before I went to medical school. And I got to work with a bunch of cardiologists in the Texas Medical Center who are some world-renowned cardiologists, and they were very influential in helping me in my career.
One of the things that I'm loving most out of these conversations and getting to talk to so many different physicians, you all have a different path, but have an equally compelling story and reason as to why you got here. And so that's really fascinating to be able to talk with all of you. Another thing I wanted to ask before we really get going, what is something interesting or fascinating or surprising about our heart that we might not know?
Yeah, I find the heart to be obviously fascinating. Obviously, as a cardiologist, that's part of what I do every day. When I try to explain to patients what the heart does, I try to do it in a way where the layperson or someone non-medical can understand.
Yeah, thank you. We appreciate that.
And so I usually use the analogy that the heart is sort of like a house. It has foundation issues, it has structural issues, it has electrical issues, it has plumbing issues. As an interventional cardiologist, my primary field of choice is the plumbing issue, the interventional cardiology issues. But also, I'm a general cardiologist as well, and then I can refer patients out for subspecialty care if they have heart failure, if they need valvular heart disease addressed, or if they have, an irregular heartbeat or something. So we send patients out to different various specialists because of that. So I kind of see myself as a gatekeeper in the community to deal with this very complex organ that serves many different purposes and frankly can have a lot of different things go wrong with it. And then also get to enjoy my subspecialty training by being in charge of our primary heart attack program.
Yeah. So I guess I'm hearing you say, when you hear that someone's had a cardiac event, or maybe even a heart attack, it doesn't mean that they've all happened the same way. There's different
there's different etiologies that can cause these events. Sometimes they're due to an ischemic issue, which is a heart blockage, which is your traditional heart attack. But they could have, an arrhythmia or something that would be another cause of a cardiac event as well.
Okay, so a minute ago you mentioned our primary heart attack center.
Yeah.
And that's a relatively new accreditation for us. Can you talk to me about what that is?
Yeah.
What it took to achieve that? Why it's so important to you?
I'm super pumped about that, actually. So the primary heart attack certification process is very rigorous. It requires us to meet certain metrics that are national standards. And if you meet those national standard metrics, then you get awarded as a primary heart attack center, which means that you are receiving top-notch cardiac care. And so that was a labor of love. And it really was our entire team, from our EMS team to our ER group to our cath lab team to all of the cardiologists on staff, the nurses. It starts from the ground up.
Right.
We meet once a month, we go over metrics within our hospital, and then we sort of improve processes. It's something that I'm really proud of because I want to practice in a facility where my patients are going to get the kind of care that I would hope my parents would get. And so for me, having that certification is huge. It's huge for our community. It's huge for our hospital. So
what are some of the specific metrics? You mentioned that we're going through those each month. What are some of the specific things that we're looking at, and can you break it down to explain?
Yeah, sure. So there's different things that we look at, door to EKG time by the time they get to the emergency room to when they get an EKG done.
An EKG is?
An EKG is a electrocardiogram. Okay. It's basically a 12-lead monitor of your heart rhythm.
Okay.
There are certain national metrics that we have to meet for that. But the biggest thing that we meet, which is the one that is heavily emphasized on, is door to balloon time. Meaning from the minute they hit the hospital door to the minute a balloon gets inflated in a patient's heart artery to open up a blockage. That national metric needs to be less than 90 minutes.
Okay.
We're averaging around 71 minutes, which is great.
That's awesome.
And overall, we continue to try to improve that process and that patient experience from the minute they hit the door to the minute they finish their procedure. And we have a great team here. Everyone's been super receptive to some of the things that we've changed. And honestly, the patients are really benefiting from it.
And as you mentioned a minute ago, there's so many different people and so many different departments that go into that.
Oh yeah, totally. I mean, for me, we as the interventional cardiologists get to kind of ride in on the white unicorn and save the day. Yeah. But the reality is that there is a massive team that has put effort into making this process go smoothly and run appropriately. And it is a Herculean effort from across the board. And so you're only as good as your team. And again, we have a really, really good team here.
And it's an ongoing thing. So we have the designation now, but we have to go through that process regularly to keep that up. So we're looking at it every day. It's
a 2-year reaccreditation cycle. We still meet monthly, still go over metrics. Things still are constantly tweaking and improving to how to get better, to deliver better patient care. And then we started adding new technology to our services that we offer. So there's always something to grow. And that's sort of, my mantra is there's always room for improvement. Yeah. So I'm always going to try to continue to make that better.
I'm also enjoying breaking down some of the complex terms that we throw around. So you just talked about EKG. We talked about the balloon, kind of what that is. What about STEMI and non-STEMI? We hear those terms occasionally. Yeah. What do those mean?
So STEMI is sort of what you see when you're watching a TV medical drama, right? It's the patient's clutching their chest, they're having a heart attack. That's a STEMI. That's someone that's having acute crushing substernal chest pain. They have some EKG changes that are very concerning, and that is where we judge our national metrics of door to balloon time.
Okay.
Now there's other types of what we call acute coronary syndromes. There's unstable angina and non-STEMIs.
Okay.
Non-STEMIs are when patients come in and they have an event. It might be the day before, it might be several hours before. They do not have any changes on their EKG and they are sort of restabilized, meaning they're not consistently having chest pain, or they're not consistently having some electrolyte or hemodynamic instabilities, meaning they're not having blood pressure issues or heart rhythm issues.
Okay. So they kind of leveled back out.
And they've leveled back out. Okay. And so in those scenarios, you have technically up to 72 hours in some cases to take those patients to the cardiac catheterization suite. And they need to be started on what we call guideline-directed medical therapy. So they might be put on some blood thinners, they might be put on a cholesterol medication to decrease inflammation, they might be put on some blood pressure medication. There's a whole cadre of things that we can do medically before we kind of intervene surgically to take care of those patients.
Yeah, that's good to know. I feel like I'm learning new stuff all the time. Okay, so it is Heart Month. February is Heart Month, and we celebrate our cardiac services in a big way. Let's go ahead and talk about what are some signs and symptoms that people need to be looking out for that could indicate some sort of heart-related issue.
Typical cardiac pain is substernal central chest pain. Patients typically say they feel like an elephant is sitting on their chest. Yeah. Sometimes they might have some jaw pain on the left side. They might have some left arm pain. They may have some left arm tingling. But generally, chest pain is the main thing.
Okay.
Women actually present a little bit differently.
Okay.
So in females, their biggest complaint is actually shortness of breath, not that typical classic substernal chest discomfort.
Okay. That's good to know. Yeah. And sometimes as women, we kind of overlook some of those things and think we'll just power through. So that's good. Women need to be looking out for that shortness of breath also.
Yeah, and in general, heart attacks don't discriminate.
Yeah.
Men and women are equally affected by coronary artery disease. Okay. So it is important for women to take their heart health very seriously as well.
And so I think I know the answer to this, but when someone's experiencing any of those symptoms, what do they need to do?
I mean, they need to call 911, honestly. So a lot of patients will think they can get to the hospital quicker. But the reality is one, we have a fantastic EMS crew. Mm-hmm. They can deliver blood products on site. They're one of the best in the country.
Right.
They can transmit an EKG remotely to activate this whole cascade of things that happen.
Right.
So if you're having a heart attack in the field, the best thing you can do is call 911 and have your EMS team out there, because there's a whole cascade of things that will get activated in the field. Right. Our team has to get woken up in the middle of the night and come in, right? So that takes some time. They have to set up the procedural suite. So that all can be done while that patient is being brought in. And should the patient have a serious event, they can provide CPR. We have the Lucas machine, which delivers high quality CPR. They have blood products they can give. They can give medications. So a lot of things that the layperson is not going to have access to, our EMS team has. Right. So it's really important to just call 911.
Right. If people haven't listened to the recent episode we just released with Michael Wallace, our EMS chief, it is fascinating. And he did go over a lot of that. Yeah, and so just to kind of reiterate that again, not only does our EMS begin providing that care immediately in your living room, on the side of the road, at the mall, wherever you are. But then they're also coordinating back with the hospital and with your team. And if somebody drives themselves, you might miss 15 minutes of that coordination. So our team can already be woken up in the middle of the night in the car on the way to the hospital and ready when the patient gets here.
The other thing that is overlooked sometimes is the high quality CPR. Yeah. Right. And so when we talk about total ischemic time, meaning how much time is between a patient is down and they are perfusing either their heart or their brain, for that matter, if they've had a cardiac arrest. Both of those organs are very unforgiving, both the brain and the heart. Yeah. So the longer you're not getting high quality CPR, the less likely those patients are going to wake up and they're going to have neurologic damage. Right. And so it is really important to deliver high quality CPR immediately if there's a patient that's having cardiac arrest.
I think that's why we sometimes say time is muscle. Mm-hmm. Right? Minutes matter. Time is muscle. When you're missing those precious moments that could be saving some of your muscles.
And that's why we track that door to balloon time, actually. Yeah. So, it doesn't account for the total ischemic time, but certainly that door to balloon time is what we can control with that less than 90-minute metric the minute they hit our hospital door.
Yeah, I know it depends per patient, but what is the average? If somebody has come in, they've had some sort of cardiac event, they've wound up in the cath lab, how long are they with us?
Yeah, they're usually here, ironically, for just a couple of days.
Yeah.
2 to 3 days is typically the standard. They get monitored on our heart monitor. They get an ultrasound. They get placed on guideline-directed medical therapy. So 2 days and they're back.
It's crazy.
It's pretty remarkable. Yeah.
One of the things I did want to have you touch on too is our cardiac rehab program. It's another accredited program we have. It is beloved in this community and it's a great thing. So can you talk about that and why that's important?
Yeah, cardiac rehab is awesome. Yeah. A lot of patients don't want to do it. It's supervised exercise 3 times a week for 3 months. Yeah. So it's usually 36 sessions of supervised exercise. It has a better outcome than any medication we give. It is better than the aspirin. It has a 26% risk reduction in future mortality. So if I can ever encourage patients to go to the gym afterwards, that is like the best thing they can do for their health. We have a great team here. There's exercise physiologists there that can help them. There's nurses, there's physical therapists. There are people that are very skilled that can help them and guide them through appropriate exercise in a supervised environment. Also, there's other patients just like them. So they don't feel alone because it's pretty common. And so that program is really, really good.
It is located right here on the Williamson Health campus, right next to the hospital in our medical office building. And I love what you said at the end about them making connections and knowing they're not alone. That's one of the things we hear most often is the friendships they make going through this program, and sometimes they're lifelong friendships that they carry outside of rehab, and that's a great way to continue their
I mean, a lot of times, unfortunately, the heart attack is the first time that a patient experiences something, and that's a serious deal.
Yeah.
And for patients who maybe aren't keeping up with their health, not keeping up with their blood pressure or cholesterol numbers, or not adhering to good things, that can be psychologically really debilitating.
Right.
And so when you're in a group with other people, you feel better about it. At least you're not alone. You're not the only person that is going through this.
We recently did a new video that we've put up on our YouTube page about our cardiac rehab program. And it follows a patient giving us a testimonial.
Awesome.
So folks can go check that out. It's a great video.
Well, it's a great program.
Yeah. We also are using these episodes to kind of give people some healthy tips.
Sure.
So what are just some of the basic tips that you want our community to know about living a heart-healthy lifestyle?
Yeah. If you come see me in the clinic, I'm going to kind of be more holistic in my approach in terms of making sure that patients are exercising. That really is the crux of prevention. There's a lot of guidance that we get from the American College of Cardiology when it comes to recommendations for prevention. Mm-hmm. So they actually say 3 times a week of 30 minutes of cardiovascular fitness is good. Now, I might take that a little bit further now that we're talking about longevity and men's health and things like that, and try to encourage zone 2 training. Some new therapies like sauna therapy has been proven to be heart healthy as well.
What did you say, zone 2 training?
Yeah.
What is that?
So that's getting your heart rate up into a certain cardiovascular zone.
Okay, I guess that means I don't do it.
There's a few new things that are coming down the pipeline. VO2 max is another thing that people are starting to track. So these are things that we don't really understand.
What is VO2 max?
VO2 max is your oxygenation saturation when you're exercising.
Okay.
And so these are things that are coming out in the pipeline that we still don't have great data for, but I think there's going to be promising things. In terms of, heart healthy diet, I always tell patients to just go around the periphery of the grocery store, right? Not going to the middle.
Okay, I like that. Okay.
So, you're getting your vegetables and fruits that are on the outside, your whole meats, your dairy products, and then, I guess bread, because I love bread.
Yeah.
But otherwise, not a lot of processed foods. And then also, obviously, smoking. That's one of the most deleterious things you can do for your body is smoke. It causes cancers. It causes progressive heart disease, strokes, peripheral vascular disease. It's like the worst thing you can do. The vaping thing, data is coming out against that as well.
Okay.
It's still, again, preliminary, so we're kind of learning as we go because that's a relatively newer thing.
Right.
But certainly, people in our community are continuing to use that as well, unfortunately.
Yeah.
Alcohol, they say to kind of limit in terms of moderation. 1 to 2 drinks a day is usually what I recommend at the most, no more than 7 to 10 in a week. But I really tell patients that alcohol is just not very good for you in general. So eating healthy, exercising regularly, and not smoking. This is not rocket science, right? I mean, these are things that most people hopefully know, but we try to encourage it.
We also hear sometimes doctors say, know your numbers. So what might that mean? What numbers do we need to be looking at?
So we sort of focus on blood pressure and cholesterol in those arenas when we say know your numbers, making sure that your blood pressure is at least less than 130/80, making sure your total cholesterol is less than 200, your LDL, depending on your risk factors, less than 100 or 70. But now we're getting some newer things. We have this prevention panel where we look at some cardiac biomarkers, C-reactive protein, apolipoprotein, and lipoprotein.
Okay.
We also sometimes use a calcium score to help sort of risk stratify patients. And so there are other things when we talk about knowing your numbers that I think will be encouraged more as we continue to learn more about the progression of cardiovascular disease.
And again, that's another reason why it's important for people to see a primary care physician, right?
Primary carers are the gatekeepers for us, right? And their job is to sort of triage patients and identify risk. So when you go to your primary care and you get your generalized blood work, they might notice something, or your blood pressure, or your weight, right? And then they'll refer you out to appropriate subspecialty care.
Absolutely. Because that's a good point, as in referrals. Usually patients get to you by way of referral. Mm-hmm. Okay, you mentioned the coronary artery calcium scan. So that is one thing that we're doing again this February for Heart Month that we're really excited about. So can you talk to us about what that is, why it's important, and how easy it is?
It's super easy. So, it's relatively inexpensive. Unfortunately, that test is not always covered by insurance companies for whatever reasons. So the hospital runs a special during Heart Month, and it is great. It is a great screening tool for anyone that is between the ages of 40 and 75.
Okay.
And if they have a some sort of risk factors for coronary artery disease, or honestly just want an answer.
Yeah.
It's super quick. You go in, it's about a 5-minute scan, there's no contrast, the radiation dose is extremely low.
Right. You don't even take off your clothes,
No,
right? You don't have to put
that's
on a gown.
You don't even have to put on a gown. You can just show up as is.
Yeah.
And they'll give you a score as a number. And the lower the better, as I tell patients. It's sort of like golf.
Yeah.
It goes from 0 to, over thousands. And if you're 0, that means you don't really have any significant coronary plaque.
Okay.
And then you get put into buckets based on that score. And then we talk to patients about lifestyle modification, sometimes medication, sometimes stress testing.
Right.
Just depends on the score and the result.
Right.
But it's a great way to screen for coronary disease.
Yeah, and it's super simple. $65. It's a self-pay. Insurance is not involved. People come in for the quick test, and then they know a little bit more about the overall picture.
Yeah, and I think, patients who really take ownership of their health, it's a no-brainer to get that test done.
And again, I feel like I need to give the disclaimer. It's not the end-all be-all test.
No, it's not.
We need to be looking at all the other factors as well, but it is one really good look into that one area.
It's certainly a helpful tool in terms of when we help treat patients with coronary disease.
Yeah. And now that we've been doing this a few years, we're having patients come to us with these amazing stories. I know one of the patients was yours and came to us and said he was asymptomatic. He had no idea. His wife made him get the test. Yeah. And he ended up eventually needing open heart surgery. Yeah. So people can call. We'll put the number maybe down in the notes of this show. And of course, people can see it on social media. We're going to put it all over. The $65 test. You have to call in February to schedule, and we'll get you in. We have the pleasure of hearing from patients, community members every day who talk to us about the compassion they've received from our care teams. Can you tell us, how do you see that show up day to day in our cardiology services?
Yeah, I think, coming to a community hospital, that's what sets us apart, honestly, is the people that work here, they live in this community, right? They're residents typically of the county that they work in. And so this might be someone's sister, brother, uncle. It may be someone that, you see at the baseball fields or the grocery store or your center of worship. So they're members of your community. Your kids want to play baseball together, right? And so that makes a difference in terms of the care for the patients. There's a little more personalized touch. And I think that's really what sets the experience at Williamson apart from a lot of these larger organizations, is that when you come here, you're getting high quality heart attack care with a primary heart attack center, and you're getting care from your community members. Yeah. So to me, that's what sets us apart. Yeah.
We often say neighbors caring for neighbors. Right. It just feels different. You still get the top-notch care. You get all the expertise. We have the equipment. We've got the tools. And then you get that personal touch as well. Yeah. I love that. I love hearing your personal story too about when your father had the heart attack, and you wished that he had been somewhere that had a higher level of care. Yeah. And I just want to personally thank you on behalf of all of us for bringing that passion here and helping us start our chest pain committee and get our primary heart attack center designation. That's just a wonderful blessing that you shared with all of us in this community.
That's really sweet, but it's also self-serving, because when I get older, I need someone to take care of me.
Absolutely.
So no, I appreciate it.
And we'll be here. We'll be here to do that. It'll be other cardiologists, but they'll be here to do it.
That's right.
Oh, good. Great. So as we've been talking about, we are continuing to elevate our cardiac services just across the board. What does that mean to Williamson County and our community members that live here?
Yeah, we have state-of-the-art technology now, which is really cool, but what it really means is that when you come here, you're getting the same high-quality care if you're going to a tertiary medical center up in Nashville or up in a major city. Which means that you're getting the same exact, in my opinion, better care because it's community driven for that heart attack patient. And so that really means a lot, that you're getting excellent high quality care close to home.
More for you, close to home. Yeah, we talk about that a lot. And why hop on the interstate and head north when you can just stay right here? Yeah. So I'm ending each of these episodes by asking my guest, what is the most rewarding part of your job?
Our job's hard. It doesn't always end up a great story. And so those days, I'll go sit in my office, have a drawer of cards from patients, and I'll read them because it helps remind me my why. Yeah. But certainly the most rewarding part of my job is like when I'm going to the grocery store and I see a patient or a patient's family member and they'll come up and give me a hug.
Yeah.
That's the best part of my day.
That's great. It makes me think, often when you see a patient, they're having their worst day.
Mm-hmm.
And sometimes it doesn't turn out the way we all would hope. And then it affects y'all. Yeah.
That part is a really challenging part of our job. And that's the hard part about being a doctor in any subspecialty is you can't really talk about those things, right? Because of HIPAA and all the patient rules. So it's important to sort of center yourself on your why.
Yeah.
And for me, that is going to that drawer
Yeah.
and kind of picking those cards out.
Because you're right, you can't take that to the next patient either, because they deserve a brand new,
100%.
fresh experience.
Yeah.
So yeah. Thank you so much for being here today. I think this has been a great conversation. I think we've shared some great information, practical tips with our community.
Thank you so much for having me. I appreciate coming on and kind of educating our community on the great things that we do here.
Yeah, and go get a heart scan.
Go get a calcium score.
Yeah, I love it. Thank you.
Thanks.